Hello, I am Dr.Shakuntala Ghosh. Today I am going to talk about a case of right side dacryocystitis with mucocele in a middle-aged patient who presented with epiphora in the right eye with swelling in the medial canthus since 6 years. These are the instruments which I use. So coming to the endoscopic procedure itself, I did it under local anesthesia. I'm infiltrating 2% xylocaine with adrenaline in the lateral nasal wall. As you can see that I'm going about 1 centimeter above the axilla to infiltrate the lateral nasal wall, anterior to the lacrimal line and the anterior surface of the middle turbinate. And I'm also keeping a xylocaine cottonoid wick in the medial canthus to anesthetize that area. So after infiltration, I use bipolar forceps to mark the incision site. So this will prevent any bleeding when I am incising and raising the lateral nasal wall flap. So gently with bipolar, I am just cauterizing the mucosa over the area where I will give the incision. It's a posterior base flap which I am going to elevate about 1 centimeter above the axilla, starting posteriorly, coming anteriorly for 1 centimeter, and then making another horizontal incision just above the inferior turbinate, and then joining both the incisions with a vertical incision, and then raising a flap. So I am using a 15 number blade to make the incision. Meanwhile, you can see that the mucocele is present here, and I will put a fresh cottonoid here in the medial canthus to anesthetize that area. Again, I am using the bipolar forceps here to control any bleeding which will occur at the edge of the mucosa at the site of the incision. So this will keep my field dry so that I can have a good visibility while raising the flap. Most elderly or middle-aged patients will be hypertensives, so because of the high blood pressure they will have a little bit of oozing when the mucosal flap is elevated. So gentle bipolar cautery can control the bleeding. So now I am elevating the posterior based lateral nasal wall flap with the help of the periosteum elevator. So this is a U-shaped flap. With the turbinectomy scissors, I am dividing the inferior part of the flap and making it free. And then I have raised the flap completely over the bone, and now I rotate the flap over the middle turbinate away from the surgical field. Next, you can see that the bare bone over the maxillary line is exposed. Maxillary line is formed by the frontal process of the maxilla and the lacrimal bone which overlies the sac. So using the Kerrison ronger, I have made a first bite inferiorly. As soon as I make the bite, the lacrimal sac is visible. My assistant is pressing the medial canthus from outside to ballot the sac, and so that I have confirmed the position of the sac. So by this method, I know that the site of the bone removal is exactly correct. Once you identify the sac, you cannot go wrong. You just have to remove the bone overlying that from superior to inferior and anterior to posterior till you expose the sac, lacrimal sac completely 180 degrees. So bit by bit, I am using the Kerrison ronger, the straight one, and nibbling off the bone to expose the medial wall of the sac. Excess bone removal is not advocated. You should remove only enough bone which exposes the sac completely and not more than that. So a 1 centimeter into 1 centimeter bony window has to be made. In the superior part, it is difficult to use the Kerrison ronger, so I am using the 2 mm gouge with the hammer to remove the bone superiorly over the frontal process of the maxilla. This is very important, so that this bone removal exposes the fundus of the lacrimal sac. Unless you remove the bone superiorly, the fundus of the sac will not be exposed, and this will lead to failure of the DCR. So here you can see that chunk of bone which I am removing with the straight Blakesley forceps. Along with that, some mucosa of the aga nasi cell which lies behind the axilla is also being exposed, and I remove that mucosa. So the bone removal should go 1 centimeter above the axilla of the middle turbinate. It is very important. Only then will the fundus of the sac be exposed. You can also use a DCR drill to remove this bone. In elderly patients, this bone is very thin, but in younger patients, the bone is quite thick. So sometimes a drill will have to be used. As you can see, the entire medial wall of the lacrimal sac has been exposed from anterior to posterior and from superior to inferior. So a good exposure is important to get effective endo DCR and to get a good nice dacryostoma at the end of the procedure. Now I'm infiltrating the medial wall of the sac with 2% xylocaine because I'm doing this surgery under local anesthesia. So the patient should not have any pain while making the incision. So I'm infiltrating with 2% xylocaine. Next, I use 11 number blade to incise the sac vertically from superior to inferior. Both the walls have to be incised, the outer periosteum and the inner endosteum. And you can see the pus gushing out from within the sac. So this has to be a single movement, a sharp movement from superior to inferior, because if the sac is not incised at one go, then the sac collapses and then it will not be visible. Next, I use a debrided blade 40 rad to remove the medial wall of the sac completely. So in my technique, I don't use a flap technique. What I do is a medial sacculotomy, whereby I remove the entire medial wall of the sac 180 degrees from superior to inferior and from anterior to posterior. Only the lateral wall of the sac will be visible with a common canaliculus opening in the upper part. So complete removal of the medial wall of the sac ensures that there is no closure or restenosis of the dacryostoma. So with the debrider, I am completely removing the medial wall of the sac. One must take care here not to injure the lateral wall of the sac while doing so. So under proper vision, I have removed the medial wall of the sac. And you can see the superior canaliculus. Now I am going to cannulate the inferior punctum with a lacrimal dilator, and then I will dilate the inferior punctum and the inferior canaliculus with gentle to and fro movements. So first I go down vertically and then turn the dilator superior-medially. Once I have dilated it, next I introduce a lacrimal needle, again in the same direction, because the inferior canaliculus will be about 2 millimeters inferior and then goes vertically down and then goes superior-medially for the next 8 millimeters. After having cannulated, you can see the tip of the needle here, and then I'm doing syringing with normal saline using a 2 ml syringe. You can see the free flow of saline from the superior canaliculus into the neostoma which I have made. You can see in the upper part the saline is coming out freely into the sac opening, and that is the superior canaliculus which is visible. The inferior canaliculus opening, the common canaliculus opening which is visible in the superior part of the dacryostoma. Next, with the turbinate scissors, I split the lateral nasal mucosal flap into 2 halves. The upper half will go and cover the bare bone which is present over the lateral nasal wall. No bare bone should be left behind. This will lead to granulation and restenosis. So this flap is covering the upper bare bone, but it should not overlie the neostoma. Next, I am putting gel foam to support that flap over the bare bone. Again, I am not using gel foam to cover the neostoma, but just to support the flap on the lateral nasal wall and prevent it from falling down. Another gel foam piece is used to evert the sac wall posteriorly and keep the opening patent. The common canaliculus opening and the lateral wall of the sac, the fundus, all these are completely exposed. Next, I will use Neosporin or soframycin ointment to cover all the raw edges and fill up that area. And this is the neostoma which is seen. The common canaliculus opening is seen in the upper part of the neostoma. Syringing done 1 week post-op shows that it is completely patent. When I am ballotting the sac from outside, you can see the lateral wall of the lacrimal sac. The medial wall is completely removed. and you can see a wide stoma, 1 into 0.5 centimeter size. Syringing is done post-operatively to confirm the patency. Again, I'm using a lacrimal dilator to dilate the inferior punctum and then the inferior canaliculus. And next, using the lacrimal needle, I will cannulate the inferior canaliculus, and using a 2 ml syringe and saline, I will do the syringing test. You can see that there is no regurgitation of saline. There is a free flow of the saline into the nasal cavity. You can see it, confirm it endoscopically. You can see that the saline is coming freely through the neostoma. And you can see the neostoma very well. So there is a free flow of saline there. So every week I call the patient to do a syringing, and cleaning nasal toilet is done to remove any crust or coagulum which may be present and confirm the patency of the neostoma. This is at the end of 1 month. Thank you.